You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you to the April 2026 edition of Editor's Summary. This month, I will be speaking to Drs. Marius Smits and Ellen Renette on behalf of all the authors of our highlighted paper titled Predictive Value of Severe Symptoms for Residual Disease After Transforming from High to Low Disease Activity in Axial Spondyloarthritis, a longitudinal study. Is there anything you want to add that we may have missed?
I think we've covered the methodology, we've covered the impact and the results of the study quite thoroughly. Perhaps one aspect that is important to emphasize is the importance of continuing to gain a better understanding of residual disease as a concept, as it is still quite new as we look towards prospects for future research. And the most important next step that we need to take is to work towards a consensus definition of what residual disease means, and to ensure that this is consistently applied both across research and clinical practice. And we hope that this study will also contribute as a stepping stone towards this objective, and is also the objective of other endeavors that we're currently undergoing in our department on the subject of residual disease and outcome measurement in Axial SPA. Because as we saw illustratively, to take our project as an example, the absence of a consensus definition was an obstacle that we encountered and is also one of the most important limitations of this study, which also affects generalizability of the results and comparison of our results to other projects in other settings. And so addressing this particular knowledge gap specifically would be beneficial, and it would also hopefully help make the transition towards broader research on other prognostic factors in Axial SPA, specifically also for the objective form of residual disease, seeing as in this study we mainly captured predictive factors for the subjective or the patient experienced form. So hopefully with these advancements in research in Axial SPA, more research will follow, and that will hopefully lead to long-term improvements as well to the management approaches in Axial SPA. And to tie this all together, perhaps to conclude with just a brief take-home message based on this study and the research that has been conducted on residual disease as a whole in Axial SPA, is to emphasize that residual disease is an important and clinically relevant phenomenon in Axial SPA that remains deserving of continued attention. And we hope to contribute through our results towards timely and effective recognition of this phenomenon, potentially also prediction in early stages of the disease, to enable better patient outcomes in the future, better explanations, better expectation management, informing future research projects, all with the end goal of implementing this as well in clinical practice and improving the outcomes, not only through the outcome measurements that we have right now, but also through measures that are important and significant to patients and all stakeholders.
I hope you enjoyed listening to part of my interview with two of the authors of the paper titled Predictive Value of Severe Symptoms of Residual Disease After Transitioning from High to Low Disease Activity in Axial Spondyloarthritis, a longitudinal study. Now we'll move on to the other articles of the April 2026 edition of the Journal of Rheumatology. The next article to highlight is part of our expert review series and is by O'Keefe and co-authors from Harvard Medical School, Boston University, and is entitled Screening for Rheumatoid Arthritis-Associated Interstitial Lung Disease, Current Evidence and Next Steps Needed for Routine Use. Approximately 10 to 15% of RA patients develop clinically significant interstitial lung disease, or ILD, with a higher percentage of patients having subclinical disease, with estimates ranging from 19 to a high of 40%. In this article, the authors review the current state of evidence for RA-ILD screening in the context of principles suggested in a systematic review by Dubreuil and co-authors in 2018. There is an excellent table in this paper outlining how these principles can be applied to screening for ILD in patients with RA. The authors then systematically go through these guiding principles and provide a rationale for screening for ILD in RA patients with one or more of the following risk factors: male sex, older age, smoking, RA-related autoantibody elevation, obesity, and high RA disease activity. These guidelines follow the 2023 American College of Rheumatology, American College of Chest Physicians guidelines for screening and monitoring ILD patients who have a high risk of developing ILD. This is illustrated in a figure in the paper. Another figure in this paper illustrates the balance between the pros and cons of screening for ILD. Both of these figures are expanded upon in the text of the paper. The authors then move on to review biomarkers and genetic markers associated with ILD. And the last table of the paper lists the components for a successful screening strategy, and the authors conclude with suggestions for further research. I suggest this is important reading for physicians treating patients with RA. We now move to SLE with a paper titled Time Trends in Coronary Syndrome Hospitalizations and Outcomes in Patients with Systemic Lupus Erythematosus, a United States inpatient cohort analysis by Parparis and co-authors from the Department of Medicine, University of Arizona College of Medicine, Phoenix, USA, University of Cyprus Medical School, Nicosia, Cyprus, the Division of Rheumatology and Clinical Allergy, University Hospital of Iraklio, and University of Crete Medical School, Iraklio, Greece. Using data from the U.S. National Inpatient Sample from the years 2006 to 2019, the authors reviewed more than 70,000 hospitalizations in SLE patients for coronary artery syndrome and compared them to more than 17 million hospitalizations for coronary artery syndrome in non-SLE patients. As compared to the non-SLE patients, SLE patients more commonly were less than 50 years old, female, African American, and had higher rates of antiphospholipid syndrome with prior thromboembolism and chronic and/or end-stage kidney disease. From 2006 to 2019, the hospitalization rates fell by 40% in SLE patients, predominantly in the last 4 years of the study, as compared to 50% in non-SLE patients. In-hospital mortality was similar between the groups, although the SLE patients experienced longer hospital stays, and SLE was associated with a higher total hospital cost. In an accompanying editorial titled Trends in Acute Coronary Syndromes and Systemic Lupus Erythematosus, Are We Moving in the Right Direction? Dr. Susan Manzi of Allegheny Health Network, Pittsburgh, USA, reviews the history of the burden of cardiovascular disease in SLE. She then importantly reviews the advantages and disadvantages of using data from the U.S. National Inpatient Sample. Lastly, she suggests that it is time to move beyond the descriptive statistics and test interventions directed to SLE-specific atherogenic mechanisms and risk factors. I will now move to a pediatric paper titled Evaluation of Health Disparities and Outcomes of Patients with Juvenile Idiopathic Arthritis by Harris and co-authors for the Pediatric Rheumatology Care and Outcomes Improvement Network. In this cross-sectional study of 9,601 patients who enrolled in the Pediatric Rheumatology Care and Outcomes Network, so-called PRCOIN, the researchers found significant disparities in patient characteristics and outcomes. Non-Hispanic Black patients had statistically higher disease activity as measured by the JDAS-10 score, a higher pain intensity score, and both physician and patient global assessment as compared to non-Hispanics whites. In addition, females had higher scores compared to males for all outcome variables. Patient age was associated with higher scores across all outcomes, even after controlling for disease duration, sex, and JIA subtype. It should be remembered, however, that the majority of patients reported in this paper were seen in the U.S. healthcare system and may or may not apply directly to patients followed in countries with different healthcare systems. In the accompanied editorial titled Understanding the Current Landscape of Health Discrepancy Research Among Youth with Juvenile Idiopathic Arthritis by Drs. Jennifer Wu and Rebecca Hetrick from the National Institute of Environmental Health Sciences, NIH Research Triangle Park, USA, and Indiana University School of Medicine, Indianapolis, USA, respectively, they point out that it's important to consider the social context around race and ethnicity that drive these disparities. Specifically, race and ethnicity may not influence health independently, but rather likely represent the social and structural factors that are embedded in society. These factors include environmental factors and political influences that may alter health care disproportionately in marginalized populations. Now, I will briefly review the other papers published in this month's edition of the journal. The first is by Whitfield and co-authors titled Evaluating Implementation Context to Prepare for Scaling Up the Integration of Interdisciplinary Healthcare Providers in Rheumatology Practices, a Rheumatology Workforce Survey. The authors evaluated the current rheumatology workforce characteristics and determinants of integrating an interdisciplinary healthcare provider within rheumatology practices. These practices were in Ontario, Canada. Their survey had an excellent response rate at 74% of Ontario rheumatologists, which covered greater than 90% of practice sites. Overall, 91% of the rheumatologists were very interested in an interdisciplinary healthcare provider model, and 65% preferred an extended role or scope provider in addition to rheumatologists. However, inadequate funding was the key determinant for the adoption of this practice, and many noted a lack of supportive climate, including lack of support of processes and resources to enable this practice change. The next paper is from Spain by Cuero and Morante and is titled Impact Profiles in Psoriatic Arthritis, an exploratory latent class analysis of the assessment of Spondyloarthritis International Society Health Index. In this paper, the authors identified 6 subgroups of patients with psoriatic arthritis based on their response assessment of the Spondyloarthritis International Society Health Index. They concluded that the ASAS high captured a diverse patient experience and may help inform individual management strategies in this group of patients. The next is another study on psoriatic arthritis. This one, however, is international and is titled Validity and Psychometric Properties of 3 and 4 Visual Analog Scale in patients with psoriatic arthritis treated with guselkumab, and is by Talat and co-authors. The authors used pooled data of greater than 1,400 participants from the Discovery 1, Discovery 2, and Cosmos studies of guselkumab in patients with psoriatic arthritis. And they showed that both the 3-item visual analog scale and the 4-item visual analog scale were valid multidimensional measures of PSA disease activity. They did, however, find that the 4-item scale had a greater face validity and had separate measurements of this joint and skin disease as well as pain. Now moving on to a paper of a much rarer disease, which is titled The Natural History of Deficiency of Adenosine Deaminase 2 Vasculitis in a Large Cohort and Factors Associated with these related damage, and is by Engelstein and co-authors. They reviewed 45 patients with ADA2 deficiency vasculitis and found that a younger age of disease onset and recurrent episodes of fever, myalgia, and abdominal pain were associated with the disease-related damage and suggested that the early use of TNF inhibitors may be associated with a better outcome. We now have a paper titled Clinical and Epidemiology Features of Juvenile Onset Systemic Sclerosis from a Nationwide Survey in Japan. This nationwide survey of greater than 3,000 institutions had a good response rate at approximately 62%. They estimated the number of patients with juvenile onset systemic sclerosis at 299, with an estimated annual incidence rate, which ranged from 0.98 to 1.59 per 1 million children, that is, people aged under 18, during the study period. In the second stage of the survey, they analyzed 130 cases, of which 65.4% had diffuse cutaneous SSC, and interstitial lung disease was present in 40.8%. More details of this large cohort are given in the text. Now, from pediatrics to osteoarthritis, in a paper by Zhu and co-authors from the U.S. and is titled Metabolic Signatures of Dietary Patterns and Incidence Radiographic Knee Arthritis, a case-cohort study from the Osteoarthritis Initiative. The authors looked at 603 participants from the Osteoarthritis Initiative and found two metabolomic signatures associated with healthy food groups that were linked to a reduced OA risk, and concluded metabolomic signatures of healthy dietary patterns may be linked to a lower risk of radiographic OA. The next paper covers a wide variety of rheumatic diseases and is entitled Prognostic and Functional Trajectories in Idiopathic Pulmonary Fibrosis and Systemic Autoimmune Rheumatic Disease Associated Interstitial Lung Disease, Insights from an Italian Multi-Center Cohort. These authors analyzed 410 patients with ILD, 256 which were SARD-related, and 154 of idiopathic pulmonary fibrosis from 6 Italian centers. They found that the 5-year survival rate was better in the SARD-related ILD than in idiopathic pulmonary fibrosis. SARD subtypes showed comparable survival. ILD pattern did not significantly influence functional trajectory in the SARD-related ILD, but rather primary diagnosis was the outcome determinant. Unfortunately, SARS-CoV-2 has not disappeared, and the next paper is titled Genome-Wide Association Study Identifies Genetic Loci for Antibody Response to SARS-CoV-2 Vaccines in Patients with Systemic Autoimmune Diseases in Healthy Individuals. In this paper, the authors found that both MHC and non-MHC loci contributed to the SARS-CoV-2 vaccine response, and that the effects were consistent across both SARD patients and healthy individuals. This data suggests that the standard vaccine strategies for individuals should also apply to patients with a systemic autoimmune condition. This month's Panorama 360 Degrees of Rheumatology is titled The Unasked Question, Musculoskeletal Symptoms in Sexual Activity. The authors reported that there were 108 musculoskeletal symptoms in 92 adults surveyed, and the symptoms were in both partner roles. This article makes interesting reading on a subject that physicians rarely approach with their patients. We have 2 images in rheumatology this month. The first is titled Bone Erosion Repair with JAK Kinase Inhibitor and shows the initial hand radiograph, which demonstrated bone erosion of the second phalanx, and 2 years later, following treatment with filotinib, showed bone erosion repair. The second image is titled Hydroxychloroquine Acute Generalized Erythematosus Pustulosis, and the figures show extensive erythematous and edematous targetoid lesion, and then desquamation during resolution of these lesions in a 25-year-old woman following 1 month of treatment with hydroxychloroquine. The research letter this month is titled Developing and Implementing Entrustable Professional Activity for Musculoskeletal Ultrasound in Adult Rheumatology Residency, a pilot study, in which the authors describe their pilot study of implementing a competency-based medical education for rheumatology residents in musculoskeletal ultrasound. With 1 case report titled Development of Successive Thrombophlebitis and Tachyassus Arteritis associated with Crohn's disease in a pediatric patient, a case report. I want to thank you for listening to this podcast and encourage you to read the complete text of all the articles in the April 2026 edition of the Journal of Rheumatology. These articles are available either in the print or the online edition of the journal. The latter is available at www.jrheum.org. And I encourage you to watch the complete interview with the authors of this month's highlighted article. And also, if you missed any of the previous articles, please take the time to review them. These are all available at our website and our YouTube channel. If you have any comments or questions about any of the articles in the April edition of the Journal of Rheumatology, please send them to me directly at esilverman@jrheum.com or to manuscripts@jrheum.com. And I encourage you to join me for next month's edition of Editor's Summary. I wish to thank you for listening.